excision for positive margins was less than 5%. 20% received radiation for positive nodes. Local recurrence was 2.6%. In those that had positive margins, the local recurrence rate after radiation was 1.7%. In the radiated group, there was a retraction rate that was greater than 25% in 6% of the radiated group, none in the other group. Of course, they weren't irradiated. Breast pain was at 6 to 12 months was 19% in the irradiated group and 1.7% with just the RFA alone. So this was a big significant difference that we only realized. So we know from 2002 in the B21 that when you we can do with small tumors, favorable tumors, that with breast cancer radiation, an 8-year treatment, 8-year follow-up, that with tamoxifen alone, that the recurrence rate is 16%. With radiation alone, it's 9%, actually, without any systemic treatment. And together, we can get down to about 3%. But the survival of those three groups is about the same. And this was done at a time when we didn't have HER2 positive testing. They only knew ER. These were ER, PR, less than or equal to 1%. So we know that we can, that most people won't benefit from radiation, that only a small percent of patients. So how we can ferret out who those patients are. And we know that there's been many trials, the Hughes trial, the Canadian trial, showing that even we can there is a selection criteria that it really get reasonable local control, but you still over 70 and fit, but not over not at 50. So and then there's other trials again with a long-term follow-up that we get reasonable 10-year recurrence rates in select women. They still benefit from radiation for local control, not necessarily survival. The IDEA Award research shows individualized decisions for endocrine therapy alone, looking at recurrence scores of less than 18, median follow-up of 5 years, really had very good 100% breast cancer survival. So this led to the energy, the BR-007 or the DEBRA trial, where the patients were randomized to breast cancer radiation with endocrine therapy versus endocrine therapy alone. Again, looking at small tumors with endocrine positive, and here now we have a time, these are all HER2 negative as opposed to the original B21, and recurrence scores are stratified less than 11 or 11 to 18. So these are very reasonable small tumors with favorable oncotype testing. So this is in trial right now. So, but we still know that radiation decreases recurrence, but in a small select group of patients, and how we ferret those out is the question. But we still, with radiation, we have a lot of side effects with fibrosis, decreased cosmesis. It's inconvenient or even impossible for some rural patients and poor patients that can't afford to leave their job or in a rural setting. And less than 80% of patients that receive their prescribed dose, really less than 80% actually get the full dose that they're prescribed, especially in rural areas, at least in the United States. Most patients really won't recur without radiation. So how can we select those out, or can we do something else? Really, it's over-treatment for most patients. It's unnecessary long-term side effects, and it's a high cost to benefit ratio. And, we say that breast cancer conservation is equal to mastectomy, but it's not always equal in the size of the breast. And the Canadian trials have shown that in 50% of patients, there's a 50% decrease in the size of the breast, or sometimes more. And we also know that the extent of disease, especially in these favorable tumors, is less than a centimeter around the lumpectomy site. And so brachytherapy has become very effective and it's actually decreased costs because of the timing of it. And but it's labor intensive for the patient as well as the surgeons. And many patients can't come in twice a day for brachytherapy, but it's also increased risk of infection, et cetera. But it is equal in terms of local recurrence, especially if they got their endocrine therapy, can be 3% in a 5 to 8 year follow up. And this is just a compendium of all the trials. But it also has problems with the type of, this is external beam, it gets fibrosis and can be quite uh, uh, painful to patients. So we developed the concept of radiofrequency instead of radiation done at the intraoperative, so intraoperative cavitary hyperthermia, basically. And it reduces the re-excision rate, reduces the recurrence, and you get a centimeter ablation. So if there's any residual tumor there, then it can be ablated with the radiation, and it obviates the need in some patients to go back for re-excision for closer positive margins. We started this with a simple surgery, simple research where we took mastectomy patients who donated at the time of the surgery, there where we could do a simulated lumpectomy and ablate the cavity, and we did whole amount. Dr. Kurian, our pathologist, did whole amount reconstruction of the ablated site, and we could show that we could get a concentric area. We also did thermal testing to see how concise we could be and how conformal we could be with our hyperthermia. And so, we then went with our colleagues in Italy, did a blade resect trial. Of course, we did lumpectomies, followed by ablation, followed by the standard at that time is a uh, quadrantectomy. And we showed that we could get, this is Dr. Code, our pathologist did this, where you could see the reconstructed ablated site there that we could get a nice conformal area around the ablated site. And here is just the pathology uh, section. We got at least a centimeter around the area. And so we could reduce the whole concept is to reduce the re-excisions, and you can see here in yellow in the mastectomy section here that we could get a very nice ablation zone around there, and it's equivalent to partial breast irradiation. And again, it would be nice to obviate the need. The patient can get it done in the operating room at the time they wake up and they're finished with anything in terms of surgery or radiation to the breast. And this is just a film showing that lumpectomy, followed by the cavity. We do a purse string, deploy this tines of the RFA. This is the original that we were doing. And we ablate for 15 minutes at 100 degrees. Then we exit the cavity there and close as you would usually do. And so it adds 15 to 20 minutes to the surgery. And this is what it looks like in real time. And I developed a technique that we validated, looking at it with Doppler, which looks like that, so we could test the size of the ablation zone. So then we did the ABLATE one trial where we did a single institution and showed that in 100 patients that we could get a reasonable look at the cavity with a Doppler. We looked at local recurrence and survival and cosmesis, and we found that we could do very well. Two-thirds of the patients with positive margins avoided re-excision, complications were low, significantly decreased pain. Two-thirds of the 100 patients avoided radiation totally, and good cosmesis, decreased costs, and comparable effectiveness in intraoperative radiation. So then we embarked on a long journey of prospective phase two multi-center trial with breast lumpectomy with the added hyperthermia in the cavity. We just published this I'll show you the results here. and it was IRB approved and FDA approved trial. Uh, Privileging was done at UAMS. I trained everybody in the technique. They came to our institution and 7 different institutions. Patients with positive, it was risk adjusted in that patients with positive nodes or aggressive disease were offered whole breast irradiation, which 20% of patients did have because they had positive nodes, which is not unexpected. And then we looked at various outcomes, including complications, margin, re-excision, local recurrence, disease-free survival, overall survival, cosmesis, changes in the mammogram and quality of life. Patients got 3 scales, EORTC body image scale, subjective cosmetic results scale, and RTOG acute and chronic scales. We had a very prestigious study and safety monitoring committee that worked with us. And these were the 7 institutions involved with the trial. These were the primary endpoints. We had 242 patients recruited to the trial. 7 mastectomies were due to positive margins, and that was primarily due to extent of DCIS. 2 other mastectomies were performed for local recurrence, one for cosmesis in an irradiated breast that was a painful irradiated breast with severe complications due to radiation, and a mastectomy rate of 2.8%. 200 we had a size of about 1.1 centimeter, but ranged from zero point 0.2 to 3 centimeters in size. Re-excision for positive margins was less than 5%. 20% received radiation for positive nodes. Local recurrence was 2.6%. In those that had positive margins, the local recurrence rate after radiation was 1.7%. In the radiated group, there was a contraction rate that was greater than 25% in 6% of the radiated group, none in the other group. Of course, they weren't irradiated. Breast pain was at 6 to 12 months was 19% in the irradiated group and 1.2, 1.7% with just the RFA alone. So this was a big significant difference that we only realized uh, there. Cosmesis was good to excellent in almost 90% of the patients. And this is just an example of the cosmetic result. And here's an example of a radiated breast on the top panel there. You can see the difference in size, and you can see the ablation zone there, but this is a radiated breast. Just you can see the difference in the right-sided panel, which is the left breast. And then the ER, this is just a typical ERF A or radio frequency treated breast on the bottom site there. In terms of the lymphoma or the long-term symptomatic relief, there was a big difference in the radiated group at a score of 5.4 versus ERFA, which was 1.5, a significant difference, much lower long-term symptoms in the radiofrequency group. So, in conclusion, we have a reduced rate of re-excision due to focally positive or close margins. It's better cosmesis, less skin toxicity due to reduced volume of excised tissue. Advantage of completing local therapy intraoperatively and local control without radiation in 80% of the patients. So, reduced cost, and you can save radiation for those who truly need it. And so we developed from there a new device that we were working on. Again, we did it in the same way, testing it on simulated lumpectomy specimens. And the nice thing about this, I did this so that it's a complete uh, uh, device where you can just plug it into the Bovie machine. So you don't need to buy a whole new unit again. So again, we did a lumpectomy. And then we deploy the device. And here you can see the device is much easier to use. There's much less learning there. It's much like an intraoperative radiation device. It's rounded to fit into the cavity itself. And you put a purse string around the top of it. And you ablate in a similar time. It's around 20 minutes for the procedure. And again, this is all surgeon so that most patients, and even in rural areas, can easily use this. Everybody has a Bovie machine, usually in the operating room, even in rural areas. And so we have shown that it gives a very concentric amount of tissue ablation. This is just our first report of 55 ablations in 44 females. And you can see we get a very concentric area around the area. And so this is the device that the FDA wants us to do just a few more patients. And this is already an approved trial that this device will be used in from the Alliance Cooperative Group. So we're very excited. So this may be the next iteration of something that was mentioned by Dr. Gant, is that we want to decrease the radiation therapy escalation that's come along with decreasing sentinel lymph node and other parts of our surgery. So it may be a new paradigm for treating favorable breast cancers, which are most of our patients, by the way. And a majority of patients can avoid re-excision and avoid mastectomy, because I have many patients from rural areas who choose mastectomy just because they can't come back for radiation. And it's a treatment that can be in lieu of radiation, and it's fivefold less painful than radiation in our series. And it can maybe increase definitive treatment compliance, because we know most patients, 80% of patients, don't complete their full radiation, which I'm hoping that's a little bit different today, because with the accelerated fast trial, et cetera, 5-day treatments, that that may be not true. Thank you very much.